Uh, So the first session of your foundation course in palliative care nursing will be taken by Dr. Sreedevi Warrier. So she'll be taking introduction, the first session, introduction to palliative care. So I'll give a quick introduction about Dr. Sreedevi. Madam has completed. Madam has completed her MSc in palliative medicine from Cardiff University, United Kingdom, and she has also a certified palliative care completed certified palliative care training from Palliative India. She is the department head of education and clinical training of Palliative India. And she is an honorary tutor of School of Medicine, Cardiff University, Wales, UK. She is also senior clinical research fellow of Department of Palliative Medicine, KMC, Manipal. She also holds a fellowship in palliative medicine. She is also a national faculty for Indian Association of Palliative Care. And thank you, ma'am. I welcome madam for the first session.
Thank you, Anu. Thank you all the participants for joining us for this program. It's always a pleasure to talk to nurses because when I joined palliative care more than 10 years back, I learned a lot of things, lot of palliative care philosophies from my nurses. So they were literally my teachers for initial few years. So it's a pleasure to talk to the nursing group always. So Senior might have mentioned in the beginning, we are expecting a very interactive session. We would like to hear stories from your side, your experience, so that we'll get to know what setting you work and what are the difficulties that you face or what are the good things we can learn from you. So it is a mutual learning platform. This is never going to be a lecture series where one person will come and teach you. So this has to be an interactive session. If there will be some questions in between. If you can, your network permits, please unmute and speak because it's very good to hear some other voice than mine all the time. Or you can put it in the chat, so I'll read it for you. So we'll start with the introductory session today, and I think we'll be seeing a little more often during the course. So I'm not putting the usual introduction to palliative care concept here. One thing I want you to take back home would be about the suffering. We all treat patients, we all treat illnesses, we all treat a lot of patients in your daily practice. So when you go back home after today's session, many of you might be already doing it, but what I want to re-emphasize during the session is about looking in a different dimension, looking in a different lens, through a different lens, when we see a patient and family who is going through suffering. So what happens when we all get an illness? Say we all have some kind of respiratory infection or even COVID. What happens when you get an acute illness? We go to a hospital. What happens? We go to a hospital, we take medicines, sometimes we self-medicate, we go to a pharmacy and at least take some medications. But in a routine setting, when something happens to a normal person, we go to an outpatient clinic. We usually take some medicines for a week or 2 weeks. We get cured and we come back to home. We may have some expenses in between. We may have to pay for the investigations or the OP or the medicines. We may have some expenses from our side, but it gets back to normal within few days to weeks, right? When you have a fever, you are back to your normal life. Once you go back home, you take leave and then you're back to your work. But what happens when someone has a chronic illness? What happens when someone who had a fall from a coconut tree or had a road traffic accident and became paraplegic? He became wheelchair bound. Or what happens to a patient who had cancer, which has spread to multiple areas in his body? Or what happens to a patient when he has underwent a stroke and he is discharged from hospital? He is not going to be uh, going back to work from the next day, right? Do you all agree? It will take a long time. He may or may not recover. Many a times they may not actually recover. They may deteriorate with comorbid conditions or something which can be related to the treatment. It's not like getting a fever. Their life is going to be very different the moment they have this illness and once they are back home. Everything around them changes. The work pattern changes, the income changes, everything changes. It is not going to be normal. Is it possible for them to go to hospital every now and then? Even if they have a fever, even if they have a small health issues, they may have to go to a distant hospital just to get the checkup done. And this happens very often. When someone is having stroke, he will have multiple issues in between. Every time we cannot or we need not have a hospitalization, we need not take the patient to a hospital. Few of the things can be done in a home care setting. So very often our patients, when we talk to them, we take the history. This is one of the very common statement that people say that doctor told there is nothing more to do. They did the surgery, they did the treatment. Now they told there is nothing more I can do. So they sent me back home. Is it a very common statement among your patients? I know there are a lot of nurses working who came from Chai. You will be working in a very rural settings. So you must be the only healthcare worker seeing them at their home. So is it very commonly seen statement or you hear this very often that nothing more I can do? Anyone? You can either unmute yourself and tell me, or you can put it in the chat. That is it something that you come across very often, that doctors telling patient that there is nothing more I can do? Anyone? Sister Alvin, do you hear that often, or is it something that we only hear? Sister, can you unmute yourself and speak? Sister, you are muted. We can't hear you. Can you just unmute? So, am I pronouncing it clearly? It is Aris.
Hi, hello everyone.
Yeah. How
Yes,
can you pronounce
I
it?
am Aris from the Philippines. Yes, that statement no, from the doctors is very common, especially for patients who do not have money for the hospitalization, wherein they can no longer afford treatment. So they would usually tell nurses that they will just take home their patients no, because there's nothing more no, that they can do because they can no longer buy the medications and they cannot afford the treatment anymore.
Thank you, Ernst, for your response. It's nice to hear some other voice in between the session. So I'll be calling your names in between. So I expect that interaction throughout the session. So this is very commonly told to us by the patients that now we don't know what to do. We are discharged back and we don't know what to do because the doctor told not to go there anymore because there is nothing more that we can. So this is a simple report that I want you to just go through. It's a big read. It has around 60 plus pages. So this is the essence of it. They say that in the Lancet Commission report in 2017 that around 61 million people around the globe have serious health-related suffering. And as a low middle income country, in a country like India, the suffering is much more, and around 10 million people going through serious health related suffering at the moment. So that is what the statistics says. It's not that very uncommon. The stroke, the paraplegia, whatever illness I mentioned, it is not a rare phenomenon. We see it almost every day in every setting. Whichever nurse is present here, I'm sure you must be seeing these kind of patients in your day-to-day practice. And we know that we pay for treatment from our pockets, not like in other countries like UK, where they have the insurance schemes and the government will be paying for the health expenditure. Here, what happens when you have an illness, you have to pay from your pocket. Any investigations, doctors say, any MRI, CT scan, even an X-ray, any medication, you have to pay money from your own pocket. How long, even if you are from a middle income family, how long you can go through these expenses? And it is shown that in India, what happens is that just because of health-related expenditure, people go below the poverty line. They are just pushed towards under the poverty line because of the health-related or health care-related expenses. Why am I telling all this? I'm setting a context where we can help them to reduce these kind of expenses. Many a times we feel very surprised seeing a lot of investigations in someone's prescription. So I still remember a lady. She was 60 plus. She had a swelling in her bone. She went to the hospital, shown it to the orthopedics department. They told, "You don't know what it is until and unless you take an MRI." So they told, "Take an MRI and come back." So she went to the, she didn't get date in the government setting. So she went to a private MRI center and asked the price. It was very, very expensive for her. She was from a very low income family. She doesn't have anyone to support. So she went back to the doctor and told, "Doctor, I could not take the MRI because I didn't have the money. What else to do?" So doctor very specifically told, "Until and unless you take an MRI, I cannot do anything. So you come with the MRI. Otherwise, don't come. Because I can't help you." She was in terrible pain. Nothing was managed. They were waiting for the MRI. So she went back home. She didn't go back to the hospital because without the investigation, she cannot go back. So we got a call after a few weeks from a social group telling that we saw a patient who's literally having pus and maggots crawling everywhere. She is oozing from the wound. We don't know what to do. So when we went there, this was a scene where she died within few hours because she was undergoing a lot of sepsis, a lot of pus and the blood. She was in the pool of blood and pus. So then we asked her what happened because we needed something, like we didn't know what it is, what we are dealing with. Then we realized that this was the story. Because she was told to take an MRI and she could not afford, she could not go back to the doctor. So this is what we very commonly see in our setting. So I'm just putting a background of what we are getting into to this training. And this is a very common myth that we see. The moment you tell that you're taking a palliative care training, or you tell someone that, okay, I'm working in palliative care, the first thing they ask you is that, oh, that is for patients who are dying. Has anyone heard this before? I still hear it even though I am from a very literate state in the country, that why are you working with people who are dying? I mean, why do they even need a care? Because they're anyway dying. Anyone in the chat? Have you ever heard people telling about, yes, I got one response from Arati. Thank you, Arati, for the response. Yes, we hear it very often. Yes. The moment you tell the patient also that about, okay, you need palliative care or supportive care, they think that it is kind of giving them a warning about death. So that is a very common myth. So then what it is? Can someone tell me what, if not end of life care, I'm telling that it is not for people who are dying. If it is not for people who are dying, so then what it is for? For whom should we give palliative care? What do you think? And what is it then? I'll wait for your responses. It need not be correct. It can be wrong. It can be right. There is no right or wrong in this thing. As I told, it's just learning from each other. According to you, what do you mean by palliative? Sister Anita, would you like to tell something about it?
Because lack of care only we are hesitating the
I didn't, it was not clear. Sister Anita, can you just switch off your video once and talk? Sorry. Here is Amita.
lack of care.
There is another response for those patients who are having like.
More, years. Yes, madam.
Sorry. We couldn't hear you, Sister Anita. Your in between your voice was breaking. So we have another response, other few responses in the chat for those patients who are having lifelong or incurable illness. Yeah. Palliative care is a care provided for the patient who needs continuous medical attention along with basic care. Yes. Thank you, Divakar and Arathi for the responses. Anyone else?
To help them for the meaningful life.
Yes, very, very true. To improve the quality of life. I guess you are all kind of already doing or have learned palliative care. So this class can be very, very easily concluded. So I'm just, I don't want you to go through or read the whole definition, but I'm just highlighting a few points which you already told in the chat right now, that it is an approach to improve the quality of life. It is not just about prolonging life. Sometimes we know that as Indians, specifically culturally, we think that death is not a good thing. So we try to prolong no matter what the situation or what the dignity that we are giving to the patient. It is about the number of days. He lived for this long, right? So it is not just about the quantity of life, but it is about the quality of life of whom? It is not just for the patient, but also for their families. We'll come to it in detail later. Why should we give that care to families? Because it is the patient who is going through illness, right? And for whom someone has mentioned about the lifelong illness, I may tell it as a life-limiting illness. Something that affects the quality of life. Any suffering that affects your health or any suffering that is because you have a health-related issue. And WHO says this definition is not new. It is an old definition. From then, WHO recommends that it should be applicable early in the course of illness. They say that palliative care should start at the time of diagnosis of any serious health-related suffering. Do you agree to that? Should we integrate from the beginning? What is the need to integrate from the beginning? If someone has a life-limiting illness, do you believe that it should be integrated early in the course of illness? People think differently, so I would like to know, what do you think?
From the beginning.
Sorry?
From the beginning.
Yes. Why is it important from the beginning? We can wait for them to finish the treatment and when only we can give palliative care. Why do you think that it should start from the beginning? So many of you agree that it should be started early in the course of illness. So we'll come to the point why we should start early in the beginning through some of the stories or real patient stories that we have seen later on. So just taking through the history of
it's not only the medical support, but psychological support also necessary for the patient to survive.
Very true, Archana. It is not just about giving medicines or giving nursing care, but it is also about giving them a psychological support the moment they have been diagnosed with a life-limiting illness. And Aarti has mentioned that it is important for mental health of patients and their family. Very true. So we, as I said, when we come to the story, I think we'll go into the details like why it is important to integrate early in the course of illness. So a little bit about the history, just to understand how it started and when it started. It was started by Dame Cicely Saunders in 1967. So like you all, Cicely Saunders was a nurse, and during the World War, she realized the importance of pain treatment, and she started treating patients with pain, and later on she realized that there are a lot of limitations as a nurse to give the care what she wanted in the way she wanted. So later on she became a doctor and a social worker. So she started it as a nurse in St. Christopher Hospitals in London in 1967. Just so that you all know who started the whole movement. So this whole movement was started in the UK in these years, and later on, the whole concept has changed. Initially, when she started, it was for end of life care, it was for cancer patients. But when we reached in the later on over years, the whole philosophy has changed from just from the cancer care. And it was started in London, but what happens in the country? Still in 2022, and we in India has very poor access to pain and palliative care. I don't know how many of you, as I said, many of you work in a rural setting, I guess, especially nurses from the child. I've seen in they work in a very difficult situation, very difficult terrain, very less medical support, and pain relief is very less accessible. Even in city like us in Trivandrum, if you ask, there are many hospitals in the place where we are situated. If you ask them, do you have access to all the pain medications? They don't have. So pain relief is not accessible to many of the patients who are going through the suffering. And that is why training is very important. We expect that all of you get sensitized about it, and we all start working towards to improve access to pain relief in the country. So we'll just quickly go through the story of Mr. A. Mr. A was diagnosed with cancer, head and neck cancer. So he had difficulties, pain while swallowing, and he went to a cancer hospital. The doctor told you have to undergo treatment, radiation, and probably a surgery. So part of your tongue will be removed, but and after that we have to give radiotherapy, but it can be cured. The moment he heard this, he went back home and he did not want to continue the treatment because you are totally unprepared. You are told that half of your tongue will be removed and you will be given radiotherapy. People don't want to get into the treatment. Even I'll get scared hearing all this surgery. So he did not go back to the hospital again. He went back home. He thought, okay, let it happen. Maybe it get cured, it may get healed. And over a period of months, we all know that it progressed. So it progressed as we expect, and he was unable to swallow, unable to sleep due to pain. So he went back to the hospital and told, now I want treatment. I think I'm unable to eat anything. I am in severe pain. So what will be the reaction typically of any healthcare professional? We told you in the beginning. Why didn't you come then? Now it is beyond treatment. No, we can't do anything. The maximum we can do is to give you a tube so that you are not hungry. You can feed to the tube. So they put in a rice tube and sent him back home so that he's not hungry. I give some basic pain medications which did not help at all. And he has a wife and 3 children, and he was living with his elderly mother also. He was the sole caregiver. We know that many of the households in the country, usually the male will be the sole caregiver or the breadwinner of the family. So he was referred to us by a community volunteer, and we went to see him, and we found him in this situation. And someone can tell me, like, what will be the most important thing that might be bothering you, or what goes through our mind when we see someone like Mr. A? I'm sure you might be seeing a lot of Mr. A's in your setting. So what would be the most important problem or the worst problem that you'll be facing? I'll wait for your responses. Yes, financial, because we cannot go for work probably anymore. Naina, you want to unmute and talk? Mr. Naina? Yes.
First of all, he should get some medication for pain.
Christy, Sister Christy.
He will be ashamed to face the society.
Very true, very true. I always ask in many sessions that if you have a relative like this, do we actually invite him for any family function? Will we be okay to have him around in a social gathering? everyone will stare on the tube and everyone will be focusing on, oh, what happened to you? Why you are putting this tube? Oh, and there will be definitely foul smelling. So many of us may not want a person like this to be around. Thank you for that. Non-acceptance, yes, very true. Like how there are still stigma around cancer, right? People still think that cancer can be spread to you. Very often, the moment patient goes out of the clinic, the relatives will come and ask you, can we touch him? Can we use the same utensils? Can we use the same towel that he used? Can it spread to us? So these are the questions still people ask. Aarti has mentioned about the financial burden and lack of knowledge or unaware about what basic things they can receive from any government hospital according to the diagnosis. As very true. We know that many government hospitals give free treatment. But what I've heard from many patients is that the treatment will be free, but reaching there is very expensive. They may have to hire an ambulance. They may have to hire someone to go with them. The wife will be accompanying, then there is no one to take care of the mother. So they may have to call someone. Sometimes people pay just to go with them, and the ambulance money and the food for the daytime. So everything is going to be expensive. And thank you, Sylvester. Very important role reverse from being the provider to being taken care of. That is a big area that we generally don't focus. Till then, he would have been the decision maker for the family. Many patients tell us that till now I decided what to do with the kids, where should they go, or how to manage the finances in the family. Suddenly, I became a person that my wife will tell what to eat, when to eat. My kids will come and hold me just to go to toilets. Suddenly, I became the least important person. I can't say anything. I don't have any voice of my own. They decide everything for me. What should I do? Take rest. So family members will be telling that out of the love towards the patient that you take rest, you don't do anything, we will help you. But on the other side, as Sylvester mentioned, there is a role reverse. Suddenly you become the receiver, you came to the receiving end from the giving end. Thank you for the wonderful, wonderful comments in the chat. And when we asked them, yes, many of you mentioned about the financial thing first. And that is exactly the patient also told that, will I be able to pay my medical bills? Doctor told he put in the tube, then I have to take some antibiotics. They told him to come back after 2 weeks just to check whether things are fine. How am I going to manage my medical expense? As I said, the treatment must be free from a government hospital, but reaching there, that is going to be very, very expensive. How will I provide for my family? I'm the only breadwinner. So my wife has never gone for work. My mother is elderly. Children are still studying. So how am I going to provide for my family? So he did not want to interact with anyone because of the embarrassment or the smell, the pain and the humiliation that he was going through. So he didn't want to talk or eat. And many a times patients tell, like, what is the point in eating through a tube? Everyone eats normally, then I'm the only one with the tube in the house. I don't want to eat like that. It is better to die without eating than having a tube in place. Many of them share that experience. And then only it comes about physical pain. There is too much pain and I am unable to sleep because of severe pain all through the day and as well as at night. And very lastly, very commonly people ask, am I going to die now? They say, I can see death right in front of me. The moment the pain starts at night, I think that I am going to die at night and my family members will know that only in the morning. So my pain increases at night because I think that I'm going to die. So you have all mentioned more. Whoever has interacted in the chat have mentioned all these points. He goes through a physical component of pain where he has pain over the wound, which is radiating to his ears and his head. He had the psychological issue of, as very clearly said, as role reversal. How am I going to live like this? What is the point of being alive? Which comes under the spiritual or existential despair. Many a times people ask, like, why God is punishing me, Or do I need to pray more? Or should I stop praying? Because I've prayed in my entire life, I've dedicated my life to God, but still the God has given this to me. I've not had any bad thing in the past till this happened to me. So why God is punishing me? Or sometimes they may think that why am I even alive? Why should I live like this? All this comes under the existential or spiritual suffering. And as you said, economic and social suffering, which comes along with any life-limiting illness. So we all come to a point where related suffering is much more than a physical distress. I'm happy that you started with the non-physical issues than the physical issues like pain. Usually people, when we see patients, especially doctors like us, we just see the physical suffering first and then we think about the other part. And whatever we see outside is just a tip of the iceberg. Only when you start seeing him as a person, as a part of family, we'll be able to understand how much ice is left under the surface. When you go deeper, then you understand the psychological, then social, then economic. Maybe in the end, you will understand the spiritual distress. And we never talk about the sexual issues associated with illness, right? None of us are comfortable to ask about the sexuality related issues, like how our sexuality related issues can be anything related to physical intimacy. People don't touch the patient thinking that any touch can be painful. So it starts from there. The patient will think otherwise and the caregiver will be doing it out of love. And as healthcare workers, we never ask those questions. We think that it is not acceptable, but many a times patients will be waiting for you to ask those questions so that they can open up about it to you. So coming back to the concept of palliative care, it was started initially in the beginning in 1960s as once the aggressive medical care is over, you are referred to a hospice. So it is essentially for no hope. But the concept has changed in decades. For decades now, it is about integrating early in the course of illness and goes along with the symptom management. So for someone with cancer, for example, he can go through the surgery, he can go through the radiotherapy and chemotherapy along with palliative care. And as the disease progresses, if it is an incurable illness, as the disease progresses, the relevance of the chemotherapy or surgery will come down. And the relevance of palliative or supportive care will keep on increasing. And you can see there is another triangle after death. What happens after death? We told palliative care is for patients as well as for the family. So this cannot end with the death of the patient because family is still there. They need to cope the absence of the person. So we continue support as bereavement support. We make sure that the caregiver is coping with the death as much as possible. Sometimes people end up in having suicide thoughts because my husband passed away. I don't know how to live, how to fight for my family. So people think that way. I think it's very common in newspapers. I don't know about other states, but in Kerala, we see that sometimes when someone in the family is diagnosed with an incurable illness, spouse suicides because they don't know how to deal with the absence. So palliative care continues even after the death of the patient. They maintain a good relationship with the family in the form of family bereavement support. So this is a wonderful representation of what palliative care is and what palliative care is not. As we mentioned in the beginning, the perception is about a dead plant. The plant is going to die. Why should you actually bother to water them? Many people still ask me, like, they're anyway dying. What is there to care? But they die. They are living till the moment they die. Right? Till then, they are alive. They need care. We may not be able to give the cure, but they need care. And it is, you can see on the right-hand side of the picture, how we nurture that plant into life. It is about giving interdisciplinary care. It is about managing the pain and symptoms, psychosocial support, preparing them for death, and restoration of dignity. It comes with empathetic communication. So this is a wonderful picture which clearly tells people what palliative care is not and what palliative care is. It is not just about a dying plant, but it is about a plant which is blooming and very healthy in its own way, and which has a support, which is supported by the entire palliative care team in all aspects, starting from the root to the branches to the flowers, even in the sky. Again, we see that, okay, the patient is old, the patient is bedridden, so I think he needs palliative care. That is again another myth. Palliative care is not for only for cancer patients or bedridden patients. Yes, it is very important in cancer and bedridden patients, but it is not just for cancer or bedridden. This letters will be a little small, but I guess you will be able to read. So these are some of the myths and the truths. We think that it is not just for cancer, but for patients with any life-limiting illness. And the moment someone refers to palliative care, they generally think that there is no hope, but that is absolutely wrong. Hope becomes less in terms of futile interventions. You may not end up in having more and more interventions, but it is about improving quality of life, as we mentioned. Palliative care hastens death. It never hastens death. It provides comfort and best quality. And there are certain studies which says that when palliative care is given, people tend to live longer. Because, for example, Mr. A, when he went to the cancer center in the beginning, if we could talk to him, like, why are you scared of? Is it about the surgery? Is it about the money? If we had the pain control in the beginning, probably Mr. A might have gone back and did the treatment. Because we are giving him assurance, we will take care of your pain, we will take care of any symptoms that you go through, but you have to go through the treatment. So when you give that support, people tend to go for the treatment and continue it because you are there as a support system. When you don't have the support, they tend not to take the treatment. So essentially, we are helping them to live longer and to go through the life with a curative treatment in a better way. Pain is a part of serious illness and dying. I think in many religions, people believe that you have to undergo pain as a part of your illness or part of your karma, but that is not it is. Pain does not have to be a part of illness and dying. There are many ways where pain can be relieved. People do not have to undergo or go through pain just because that you have an illness. And very often, everyone says, oh, you give medications to hasten the death. So morphine is not a drug which is used to fast forward the death pathway, but it is used for pain management and management of breathlessness. That is a drug, it's an analgesic, not a medicine which is used to hasten death. And many times patients will ask you, if I take pain medications, will I be an addict to it or will it get more useless? But if you titrate accordingly, if you know how to give medication, how to prescribe and how to de-prescribe, that is not going to be a problem. So palliative care starts at the onset of any life-limiting illness. It increases its intensity when the patient is going through the terminal illness. Again, more and more care is needed when someone is pre-actively dying and then actively dying. So we believe that a person needs the most care, the most attention, the most nursing care, medical care, psychosocial support when they are going through a pre-active and active dying. Just because that they are dying doesn't mean that we don't need to care for the patient. The care element intensifies. The teamwork intensifies as it progresses from the diagnosis till death. And we know that in the country, now you all will be seeing a lot of patients, apart from cancer, diabetes, cardiovascular illness, chronic respiratory like COPD, interstitial lung disease. You might be seeing a lot of patients with all these illnesses. And it is not just about cancer. More than cancer, there are many illnesses that people go through which needs palliative care. I'm not reading the details. You will be getting the presentation, but this is just for your understanding that it is not just cancer, but many illness other than cancer has a prolonged suffering. Even in children, we can see that it is not cancer again, it comes in the first. It can be neonatal conditions, congenital abnormalities, or malnutrition, meningitis. These are the issues which may warrant palliative care than cancer. So cancer comes to a very, very small category of patients than non-cancer. And diagnosis is not the criteria. We cannot say that, okay, you come under this illness, you get palliative care. If you come under this illness, you will not get palliative care. That is not how it works. We have to see whether the patient is going through any serious health-related suffering. It is not based on the diagnosis. Diagnosis is not the criteria for referral to palliative care. Many a times, very recently, when I talked to one doctor for one of my friend's mother, she was in severe pain but with non-cancer. So I spoke to the person, a doctor who is nearby to them, and asked, can you register them under palliative care? Because this person is in severe pain and she may need pain medication. Then suddenly the response was, but she doesn't have cancer. So it is not just about cancer, it is about any serious health-related suffering. And it is not just for adults, it is for children also. We always forget about children. There are a lot of children who are born with abnormalities, who go through life-limiting illness during their early days, but they live longer. For example, we have children with cerebral palsy, chronic kidney disease, or hemophilia, sickle cell anemia. In many of your places, you might see a lot of children with sickle cell anemia who will be going through terrible pain. And their life is compromised. The quality of life is very well reduced because of the illness. So it is not just for adults who are old, bedridden, but it is also for children with life-limiting illness. And as I said, there is a study which was done which has shown that people who got palliative care early in the course of illness, their survival was better. They lived longer. So palliative care is not a warrant that we give, okay, you are going to die because you are here. No. It is about improving the quality of life as well as improving the survival. And it has to be given at the place where they are and when they need it. It is not just about telling the patient to come back to hospital. Sometimes it may not be possible to come to the hospital all the time for the review. So it is about taking the care from the hospital to where they are and when they need it. And we know that the terrain is not very easy in many of these places. I think Kerala will be much better in terms of availability of public transport and stuff. But otherwise, it is very, very difficult to reach these places. And I always asked myself, without any illness, I find very difficult to climb all this terrain. So how are we supposed to call a patient to me just so that I can tell them, okay, everything sounds normal, you can go back? They need at least 4 or 5 people to shift the patient from their house to the hospital. So it is very, very important. Home care is the keystone or the cornerstone of any palliative care services. Whatever compassion and care that you give, it doesn't matter when you give them at the time when they want and where they want it. And it is not just for the patient, it is about involving the whole family. In this picture, it is very difficult to say who is the nurse, who is the family member, right? The doctor is wearing the stethoscope, so it is easier to understand, but otherwise, the team is very much working with the family. The family functions as the team. You can't go to the patient's house every day. The family is going to be the team for the patient. So it is about empowering the family so that they can take care of the patient. And we cannot forget kids. It is not just about kids with illnesses, but it is about the family, kids in the family. They have thousands of questions. What is happening to my dad? Is it because that I did something that dad is going to die? Should I do something more? Or all these questions come from children, and we have a children's collective, kids collective. We give them counseling sessions so that their questions are answered. I'll just quickly go through another story about a 45-year-old female. She had 2 children and she had advanced breast cancer which spread to her lungs. And we got a reference for a home care. And the moment we went to the home, from the gate itself, we could smell the wound. It was very foul smelling and we could hear someone weeping in pain. So we went inside the house. What we saw physically was a pain big fungating wound with a lot of maggots coming out of it. And the arm was completely swollen with huge lymphedema and lymphoria. She was having, in between all this, she was having nausea, vomiting. And she was very breathless because of the metastasis to her lungs, and she could not sleep due to breathlessness. And when we asked her, what is bothering you the most? We actually thought it is going to be the maggots, because worms coming out of your wound is not something that you want, that you ever want, right? And anything else can be tolerable, but seeing the worms coming out of the wound is not pleasant or something that we wish for in our life. But she was bothered about the two daughters, that they are unmarried or they are unemployed. They just finished their basic education. I don't know what to do with them. Now they are sitting with me 24 hours, taking care of me. And one thing she told us was, my husband doesn't come near me. So here is what I mentioned about the sexual issues. My husband doesn't come near me. He doesn't touch me anymore. He stands outside the room. He buys everything. He's a nice person. He buys the vegetables, whatever is needed for the house. He talks to the daughter, but not to me. He doesn't come near me. So she was thinking, I'm a dirty person. I stink. So my husband doesn't want to come near me. And the doctor told, when she explained about all this to the doctor told, okay, no need to come for the treatment because it is an advanced breast cancer. We don't have anything to offer. And when others visit, we know that when someone is ill, the neighbors and all come with a lot of fruits and eatables, which they cannot probably eat in their lifetime. They might be breathless, they might be in pain, but irrespective of that, they come to visit. When she saw, she told, I'm stinking. I cannot tolerate my own smell. So I feel when others come, I feel very embarrassed. And I feel that because of me, my daughters are stuck at home. My husband doesn't even come inside my room. So in this situation, why should I even be alive? So it is a very common request telling the doctor, why don't you give me something so that I can die? Just give me some medicines. Why should I go through all this? And why this is being given to me? I didn't do anything wrong in my past, and why God is punishing me like this? And here we saw all the elements of suffering. But once you start having conversation with the husband and the children, the husband was so sad to go near her. He did not have any clue whether he can touch her. He was thinking, if I go near her, she will have pain. He could not bear the suffering that the wife was going through. It was not hatred. He was such a loving husband who did not want to see the suffering or go near or give pain to the patient. So there's a lot of communication gap, and the wife thought he hates me because I have a big foul smelling wound. That is where our team intervenes to understand what is going on in the family and help them to be together as a team to deal with the illness. And what we did is that she was very sick to travel. So we provided home care, and we usually give medicines based on the proxy report. Husband can come to the clinic and tell how the pain is. We can give medications according to the proxy. And this is a home care team just to take you through. It will have, we pack the bags with all the medications and basic procedures, whatever is needed at home, with all the forms, the physical forms that we carry. And we help them to make their life, as you said, improve the quality of life as much as possible in a home setting. It is about integrating the patient into the home. It is not taking over the patient and, okay, now we will take care of the patient. It doesn't work like that. The patient is the happiest when they are with the family. So help them to live with the family in a better quality of life is what we aim for. And many times we help them to find a way to live on their own in terms of vocational rehabilitation. Many of you might have seen, or you might be already doing this. We teach them some skills with which they can earn some money to the family. And children to continue their education, sometimes they may be so disabled that they can't go to a normal school. We ask them what do they like, and we help them to do something which keeps them engaged and which makes them feel that they are also normal. So as I said, it is not just about giving medications or giving end-of-life care, but it is all about life. It is never about death. It is about the person who is living. And what we did for Miss M, we gave her pain medication, as someone said, managing the pain. Without managing the pain, you can't go into the psychosocial spiritual aspect. When someone is screaming in pain, you can't ask them, how are you coping and what is your social situation? We cannot ask. The primary thing is to control the pain and control breathlessness and giving dignity by cleaning the wound. Foul smelling wound is something which people cannot tolerate. So it is very important to keep their body as clean as possible and give them dignity as much as possible. And we taught the doctors how to do wound care at home in a simple, cheapest way possible with cheapest medications and resources available. And then we talked to the husband, like, why you are not being here. Then only he started bring up about. He just burst into tears, telling that I really want to be with her, but I was not sure whether I am, because her hands are swollen. So he was very scared. Am I going to give more harm? Am I going to give more infection? Can I touch the wound actually? So he was very much worried about it. And very importantly, we have to have an advanced care planning and start the conversations about that in Miss S, because he was having a very advanced illness which has reached almost in a very bad shape. So by that, I'll end my talk and I would like to hear from you all. Any one of you see these kind of patients in the community? Are you already involved in such care? Or any questions that you want to ask me? You can type it in the chat or you can unmute and ask. I'll wait for 2 minutes.
Yes, ma'am.
Marcella? If you have any questions, you can just write it down in the chat box.
Teachings included in palliative care, just to add some positivity in everyone's life dealing with illness. It is an integral part of any palliative care that we provide. The only thing I think in our country is that we know that we have thousands of religions and belief systems, right? Not like in any other country. Everyone has their own belief system and religious practices. So it is very sensitive not to impose my preachings to them. I may have some religious beliefs or spiritual. I may be an atheist or I may be another religion believer. I should be very careful not to impose my own preachings or my own belief systems to the patient. It's very important to understand what is spirituality for them. It's a very ambiguous area. It is a very sensitive area also, especially in the country. You can't just tell them what to do. We have to explore what is the meaning of spirituality, what gives them, what is the most important thing in their life, what makes them feel that they are alive, what makes them feel that they are a part of this, and then understand more of it. So, for example, sometimes patients says that I would like to hear the Quran. If someone reads near me, I feel very comfortable. Yes, definitely, that is what makes you comfortable. That is what spirituality means for them. Sometimes they say, no, I feel meaningful when I do this particular work. So I remember one lady describing, if I'm not cooking and taking care of my children, I don't feel that I'm alive. That is the whole meaning in my life. Providing for my kids is the meaning for my life. So when I lose it, so she was amazed. I mean, she is a very good cook, and she was so distressed. She was going through an end-stage illness. The most distressful thing for her was that she's unable to cook, and she was admitted in a hospital when I was working outside Cali. So then I asked, "What would you like to do today?" So pain was controlled. Then she told, "I really miss cooking. That is keeping her like so much of distress." She was not even smiling. So whenever we give something, she's like, "Oh, I used to cook this. I used to cook." What we did is like we arranged something. I told, "Okay, today you are going to cook for us. There is no food being ordered from outside in the hospital. Just cook for us, whatever you feel like." She was a little sick to stand and cook, so we arranged the wheelchair and we made her cook delicious dishes for everyone and we enjoyed. The moment we did that, she started smiling. She's like, "Now I feel that I'm alive." This gives a most, I take that as a spiritual care. I don't know how many of you agree with that. For me, that was giving a spiritual care for her because she was feeling that she's alive and she's meaningful for that day. So that brought a lot of difference in her pain management. I still have the photograph of her cooking in the kitchen and serving everyone and the wheelchair. So that's for me is a part of spiritual care. We do not have a training on how to give spiritual care because, as I said, it is a very ambiguous, very sensitive area. But it is about being open to what patient wants and to create ways to reach them. That's what I would say to that question. I don't know whether I have answered your question, but that's how I take it. I just try to read a few chats. Yes, so there are people who are working in palliative care settings. I understand. I can see. But your name is written as Galaxy 8, and so I mean, I don't know, someone has sent a comment. It'll be good to put your name so that I can call your name, and that's what I prefer to do. Yes, Mr. Belvin is working in a palliative care patients in our hospital. So I'm sure that you have a lot of experience than what I have just said to you in last 1 hour, probably.
Marcella also working in palliative care.
Okay, Sister Marcella. Glad to know that. Yes, Arati. So thank you for the response. So exactly, being a little flexible and looking according to what is giving them the most meaningful moment. Yes. There is a question regarding acute pressure. I think we'll come to that during our sessions on symptom management. I believe everything has its own route. We can't say no to anything. Anything that the patient wants, patients feel good, anything. I think that has a major role in palliative. I think I overshot by 5 minutes probably. We can move on to case presentation. I'm happy to take questions after the case presentation also. And I'm happy to hear from you if anyone of you want to share an experience. Many of you work already in palliative. Just give us a moment to start the presentation.
I am very much sure that as nurses, most of us have encountered or like have seen, may not be purely palliative care patients, but some patients requiring some of the elements Madam has beautifully touched. So we always tend to do like how much ever possible, and like we try to do our best for the patients. But what I have learned is, before starting, as we start to do something for our patients, we have to take a small pause and analyze and assess what is the expectation of the patient from us. Sometimes, we give so much to a patient, but the patient maybe requires something else, but in a very small amount. So that was something actually I learned when I started doing palliative care, something different from the general nursing that I did. So always ensure that, or always try to understand what is troubling our patient, and what is the requirement that the patient is expecting from nurses, and to have that, and to understand that we need that close association. How we say, rather than nurse patient, that person to person, that type of closeness. You have to make yourself free so that they can talk to you. So that's the only thing that I really wanted as from the palliative care nurse's point of view. And I wish to welcome Mini P. Nair for case presentation, if she's ready.
I'll just say that today we'll be presenting from our side, just to show you how the whole program goes. Like there will be a lecture and interactive lecture followed by a case presentation from one of you. So as mentioned in the beginning, you have to start sending your presentations according to the topic for the particular day, because then we have to read it before the session. We have to send it to the experts to go through it and bring in the discussion. So today, as it is the first session, we thought we'll do one sample presentation from our side so that you will understand how generally every day the course goes. So over to Sister Mini.
Okay, good evening, all. Happy to see you all. Thank you, Anu sister and Dr. Sreedevi. Today, I'm going to present a case presentation is here, and I'm going to present a patient with a traumatic arterioparesis with a stage 4 pressure sore on sacral region and left gluteal region. So the presenting complaints were on the time of admission where he was constipated since 2 days and bed sore over sacral region and gluteal region, moderate pain over the hip region, and urinary leakage was there. And next we go to the history of illness. He had a history of fall while carrying weight followed by neck pain and weakness of both limbs, and was diagnosed with traumatic arterioparesis in August 2015. Admitted and got treatment from one of the government hospitals and discharged after 1 month. So he then after 6 months, he developed a bed sore over the sacral and gluteal region, that is stage 4, and iron deficiency anemia, and again got admitted in MCH, blood transfusion done, and referred to Palliative India for wound management. And at that time, the present complaints were history of pain over the hip and wound site for more than 2 weeks, pain over the hip region, pain score of 5/10, intermittent burning pain bilateral, and wound site, there is also pain. The pain score was 4/10, continuous throbbing type of pain was there. He was constipated since 2 days and disturbed sleeping pattern, and decreased oral intake was there, and urinary leakage was there. On examination, patient was conscious and oriented. Temperature was 98 and pulse was 82, respiration 20, BP 120/70, and system within normal limits. Pressure score was there, and that was stage 4. Exudate was present, tunneling was there, irregular in shape, and there was foul smelling. And routine investigation was done. Routine investigation results was like this: HB was 10, TC was 34,000, polymorphs 80, lymphocytes 18, and eosinophils 2%. Platelet was 1.6, and serum creatinine was 0.9, serum sodium 132 milligram, and potassium was 4 mg. And about his psychosocial and spiritual aspects. 39-year-old unmarried man living with a 65-year-old mother in a rented house. He was living in a rented house with his 65-year-old mother. He has one sibling and he is married and living separately and no caring and helping them. And there was no support to this man and his mother. His sibling was living separately in another home. He was a manual labor and was breadwinner of his family. He was the breadwinner of the family. Now his mother is a manual labor and she is taking care of him. Now he can go for the job. That's why his mother is taking care of him and she is also a manual labor. Now the main source of income is from mother's daily wages, her pension and some of his friends. So concerns about his income, he is getting his income from mother's daily wages, her pension and the help of some friends. And he have taken around 1.5 lakhs loan from a private finance bank for his treatment for purposes. And he is a Christian devotee, now unable to go to church. This make him very sad. He is communicate through the phone only. He says to his mother, like his cottage like this, I don't think I can walk, so please don't spend money over my treatment. That was a statement like, I don't think I can walk, so please don't spend money over my treatment. Then, on admission, treated him with he has iron deficiency anemia. So tap ferrous sulfate 200 mg BD given, tap folic acid 5 mg 1 OD given, and dressing with Megagil ointment. Change of dressing with the Megagil ointment. There was a tunnel there, so dressing and ointment application given. And his main concerns were pressure sore, and that was 4-stage. Tunneling was there, pain, and financial problems were there. And going to the summary, like 39-year-old man with traumatic arthroparesis with bed sore, present over sacral and gluteal region. Stage was 4 with pain over the hip region. Then coming to the discussion point. First one, do we need to provide palliative care for this patient? Second one, what are the problems faced by this patient? Third one, what all can be done for this patient and his mother? So I'm expecting valuable discussion points from you people.
Over to you, Anu, for further facilitation among the participants.
So either you can unmute yourself and give answer to the questions asked, or you can give your answers in the chat box. Do we need to provide palliative care for this patient? What are the problems faced by this patient? What all can be done for this patient and his mother?
Yeah.
Yes, sir.
Yes,
We
good
can-
afternoon. Good afternoon.
Yes, sir, we can hear you.
Yeah, please. Anu, can you see the chat? There are a few comments in the chat. Someone else wanted to talk something. Sister Jasmine.
Yes, we can. Yes, ma'am, we can give like this patient to palliative care.
I think Dr. Mehboob has raised her hand.
Yes, hello, very good afternoon to everybody. Hello.
Good afternoon, ma'am.
Yeah.
We can hear you.
Yeah, I'm a naturopath During my study time, I have, after post-basic BSc doing sister tutor's job in LTMG hospital, I have trained myself in naturopathies. I know physiotherapy and many pathies along with. During my posting also, I have treated many patients, for the pain with acupressures and some mudras, some breathing exercises and all. So that's why I raised my questions that we can do practice acupressure for all these patients. And regarding our this sample presentation, I would like to say that dressing, the main concern points were the pressure source and pain. For the pain management, we can do some acupressure points as well. Breathing exercises are more effective to reduce the pain. I myself have taught in senior citizens near my house. There are senior citizens who are collected. I teach them to reduce the pain, and breathing exercise, the more oxygen consumption and retention of oxygen reduces the pain. And we can reduce the consumption of medication and painkillers with that therapies. And especially the financial crunches, suppose if there are some corporators and some political leaders, they have their funds in their hand to help such people. We can approach them as well to help these people. So this is what my answer. Thank you so much.
Thank you. Sylvester, you can speak directly.
Yes. Good afternoon. I was to talk and say the patient definitely needs palliative care because the patient has a life-limiting illness, and
Yes.
it's a patient who has been bedridden and also not mobile. We will need to give palliative care because we'll take on the different aspects of total concept of pain. Then from there, we can see if we are going to manage according to the 4 domains, which one we are going to start with as per the priority. Then see if it is pain, or even if it is about the physical issues, we manage the physical issues, we manage the social, the emotional, and the spiritual issues. So the patient definitely needs palliative care, both for the patient and the caregivers, the family. Thank you.
The patient requires palliative care. So who will be answering to the questions? Question number 2. What are the problems faced by the patient? You have already answered. Like daily dressing, position change, physiotherapy, regular medicines. Anything else?
Financial problem.
Can someone list about the psychological issues or spiritual issues? Imagine somebody, imagine someone who is just, taking up this kind of a tough and rough journey. So what all are the psychological and spiritual issues here? Issues, problems, psychological and spiritual problems. Madam has listed so many problems.
Yes, patient will suffer psychologically. He will be thinking that I am unaccepted. Feeling of loneliness. So there we have to give psychological support, sit with him, help him. By giving quality care, he may think I am loved by everyone.
Spiritually? Very good answer. Spiritually? Anybody can answer what all things he might be thinking if he, suppose he was a very religious person.
We can give spiritual support also, that patient, one who is sick, not because of his sin, but every human being will suffer some and other way. So we have to inculcate in him that God has given this pain. We have to face. Today you are sick, tomorrow I will be sick.
So as mentioned, like first we have to have a proper understanding about what exactly the patient undergoing. So before starting up with advices or maybe like comparing, we need to understand like we should have that listening ears to understand the world of the patient properly. What all can be done for this patient and his mother? Third question, the final question. Third question, if somebody can answer, you can find the time. What kind of support you think? You can be very free. You can, everybody, like all are requested to jot down the answers.
Psychological support.
Psychological support.
Counseling the patient and the family members.
Mhm. Okay. Ma'am, anything else to do, ma'am?
I think someone has mentioned in the beginning that there are a lot of government schemes which might be available. So it's important to, as a part of finance, like we can't give money to all the patients, right? So it's very important to understand whether there are any schemes available for patients with paraplegia, whether we can help them with availing those schemes, because there won't be anyone at their home to go and give the application and get the schemes. That is one thing, and you rightly mentioned about supporting the mother, right? They may want 1 day break from everything. They thinking about the mother, a healthy son now is on wheelchair, so she may have to give bath or all the body care to such a grown-up man. It kind of losing dignity for the person who is in suffering as well as for the mother. She'll be going through a lot which she may be unable to share with the patient. So it's very important, as mentioned, that just to be a good listener and let her open up her emotions. Many a times they may need counseling separately. Some of them may need evaluation, whether they are going through any depression or something. And very importantly, their healthcare needs. So we have noticed in our registration form, we have a specific questions on caregiver, whether they are taking any medications, whether they have any comorbid illnesses. So what happens typically, if suppose, imagine the mother has mother is a hypertensive. She might be taking hypertensive, antihypertensives for many long time. When the son is there, either she may forget to take the medications, or she thinks that, okay, some money is there, it's important to buy medication for the son than buying my BP medication. So ultimately, she may end up in suffering, and we see that a lot. Suddenly they faint in the IP, we check the blood sugar is over the roof. Then they will tell, I was on insulin, but I was taking care of him, so I didn't take that for a month. So it is very important to go through or understand whether the caregiver has any health issues. Do we need to give support or check whether they are taking their own medication? So that is another part that we need to communicate, and empowering the caregiver to take care of these things at home. And someone has mentioned about daily dressing. It's not possible for you to go every day and give the dressing, right? It's not possible. We can't go every day to patient's house. We need, so who is going to do that? Either you should have a community, neighbors should be able to or willing to help the patient, or the primary caregiver should know how to do it in a very low cost, or which is something which is doable at home. So these are the things that we need to take care of this patient. And rehabilitation, help them in physical as well as vocational rehabilitation. Help them to do activities on their own as much as possible. So he's a paraplegic, so upper part of the body will be stronger. So if you teach them how to get up from the bed on their own, how to shift himself to the wheelchair, how to avoid bed sores, how to do an intermittent catheterization rather than on a long-term Foley's catheter, how to take care of the bowels. All this education will play a major role. Otherwise, they will end up in having some kind of infection every now and then. They'll be just lying down on the bed without moving and end up in having worse bed sores ever. So he already has bed sores because they don't know how to move. Sometimes the injury can happen while shifting. So it's very important to emphasize on the physical rehabilitation and help him to find something that he can do at home that we need to market and give the money. So those kind of vocational rehabilitation also has to be considered. And once in a while, bringing them to a support group where there may be other wheelchair bound patients, there are other paraplegic patients. All of them can come together. Now everyone uses Zoom, right? Even the patient, we use telehealth, we do patient get-togethers over Zoom platform. So just once in a while, meeting with other patients who are on wheelchair, just to talk about what happened. So I myself have witnessed how they pull each other's legs, talking about their disability. Or I'm more disabled than you, so you can't talk. I'm the first one to talk. So these kind of things happen between them, which we don't imagine. They take it very positively. So they were even claiming, I'm 15 years in wheelchair, so I'm the senior most in this group. They're not taking it as a disability for 15 years, but they just talk about it in a very positive way. So we have to encourage those kind of support group meetings whenever possible. That's all from my side. If there are any other points that we missed, you can ask. Or probably we can wind up today's session. So you are given a template like this. It's very simple, 4 or 5 slides. You don't have to spend a lot of time on that. You need the basic details, which needs good discussion points. You need not use the same questions. You have to ask questions that comes to your mind, like how to manage the pain or sometimes how to talk. So whatever questions come into your mind, please feel free to write the discussion point so that we can get input from other participants also.
Shall we wind it up on today's session?
Yes, and yes.
If there are no more questions or comments, we can wind up today's session. Thank you all for joining us today, and I'm requesting all to keep your videos on if possible throughout the session. And I have shared the feedback link in your WhatsApp group and in your chat inbox. Please go through it and fill it up. Sending feedbacks is very important for us. Thank you all for joining us. Thank you, Sister Anu, and thank you, Dr. Sreedevi, for joining us today. And thank you, Sister Minu, for that wonderful case presentation. Thank you all, and bye. We will see you on the next session, that is on Saturday.
Thank you all for joining.
Thank you. Thank you very much.